Professor, welcome. Virtual stage is all yours. Thank you.
Thank you very much for your introduction. First of all, I would like to thank Professor Sergio for his kind invitation, asking me to present, have a presentation at online neurosurgery meeting. And the topic he has asked me to present was Scheuermann's kyphosis. I also would like to apologize for the inconvenience caused to you as a result of an error in my computer last Monday. I appreciate your patience. So let's start with the topic Scheuermann's kyphosis. So what is the definition of Scheuermann's kyphosis? Scheuermann's kyphosis is a deformity of the thoracic spine that develops during growth. It is second most common cause of back pain in children after spondylolysis and spondylolisthesis. What about etiology? The etiology of Scheuermann's kyphosis is unknown. There are theories that the condition is due to mechanical, metabolic, and endocrinologic problems, but this has yet to be proven. As far as genetics is concerned, Scheuermann's kyphosis is a hereditary condition, but it is multifactorial. So there is no clear inheritance pattern. It's very similar to adolescent idiopathic scoliosis. What about the incidence? Prevalence of Scheuermann's kyphosis is 1 to 10% in adolescent population. It's very rare in patients under the age of 10 years. There are associated conditions with Scheuermann's kyphosis like spondylolysis, spondylolisthesis, and scoliosis, and this varies between 6 to 25%. Demographics, usually Scheuermann's kyphosis is detected at puberty in skeletally immature patients. Males are twice as likely to develop Scheuermann's kyphosis than females. Scheuermann's kyphosis, I don't know, some of these pictures is obstructing my view. Scheuermann's kyphosis, can you see all these three pictures here? Okay, because your pictures are on the right-hand side, it's covering a part of my screen. Okay.
Yeah, we can see the full screen.
All
it's
right,
probably
okay, that's good.
only
Scheuermann's kyphosis is seen in two different curve patterns. This is type 1, as you can see here. The apex of deformity is at the mid-thoracic region between T7 and T9. This is a normal spine, and this is type 2. The apex of deformity is at the thoracolumbar region between T11 and T12. I want to bring your attention towards the pelvic incidence in type 1 and type 2. You will see in type 1 is much larger than type 2, and of course, I will discuss this one later. Could I ask Dr. Sadeghian just clear his picture from my screen, because otherwise I can't see the bottom part of my
I think it's probably your view. You should magnify it or take it, like you can just drag it and put it away. Yeah.
Oh, is that right? Okay.
Yeah.
All
because
right. Okay.
Yeah,
that's better. I can see at least my screen. Yeah. Okay. What about radiological evaluations? Plain radiographs are very, very important. Lateral standing view of whole spine is needed for correct diagnosis. That should include cervical, thoracic, lumbar, pelvis, and hip joints. Lateral X-ray with the patient hyperextended over bolster demonstrates the degree of stiffness of the curve. And this is very important before surgery. You assess the stiffness of the deformity. MRI is used if neurological findings present during clinical examination. CT scan can be used if you want to assess vertebral wedging and Schmorl's nodes. What about diagnosis? The distinction between poor posture or postural kyphosis, usually you can see in tall people, and Scheuermann's kyphosis is that the Scheuermann's curve is much more rigid and does not correct with hyperextension. What about diagnostic criteria? Thoracic kyphosis more than 50 degrees, anterior wedging more than 5 degrees in 3 or more vertebrae, as we can see in these images here, and this one here. Disc plate narrowing at the apex of the curve, as well as end plate irregularities and Schmorl's nodes. What about symptoms? Thoracic pain usually is centered over the apex of the curve. Back pain is severe when excessive lordosis is present. Absence of radiating pain to the lower limbs, they usually don't experience any radicular pain. Reduced range of movement of lumbar spine in majority of cases, and hamstring tightness in almost in all cases. Restrictive lung disease has been reported in patients with a curvature greater than 100 degrees. What about treatment options? Treatment of Scheuermann's kyphosis is dependent on the degree of kyphosis, skeletal maturity, severity of pain, neurological compromise, and of course, self-image. Non-operative treatment should be considered in the young adolescents with a kyphotic deformity less than 50 degrees with no evidence of curve progression. Brace treatment reasonably successful in preventing progression in skeletally immature patients. Curves greater than 70 degrees respond less favorably to brace and therefore should not be used. Brace with over-shoulder straps is recommended, as you can see top right, for the upper thoracic curves. Some people believe that Milwaukee brace should be used. I don't usually use Milwaukee brace because the compliance with this among the children is very, very low. They don't like it. It's not comfortable. I use just over the top one as a part of upper thoracic curve. For the lower thoracic kyphosis, you can use TLSO or joint brace. Surgical options, curve should be greater than 70 degrees. Evidence of neurological deficit, intractable pain, unacceptable self-image, and curve progression. Most cases can be managed by posterior approach alone. However, anterior surgery is needed if deformity is very rigid and curve is more than 100 degrees, especially in adult cases. Surgical treatment, posterior correction alone with multi-level pontosteotomies and segmental screw fixation, in my opinion, is the treatment of choice. Combined anterior posterior correction is considered in curves more than 100 degrees, especially in adult cases. 3-column osteotomies, PVCR, may be necessary for very severe and rigid deformities in patients who are not a good candidate for anterior surgery due to pulmonary disease. Selection of upper and lower instrumented vertebrae. Lower instrumented vertebral LIV, you draw a line which is called posterior sacral vertical line, which is this line. The most proximal vertebra touched by this, and that's the lumbar region, is a 5, 4, 3, 2, 1. This is touching with this line in the lumbar region. This is called sagittal stable vertebra or LIV. And that's the way you choose LIV in Scheuermann's kyphosis. Upper instrumented vertebra, usually in my experience, T2 in majority cases is the best level to choose. Conducting such an extensive surgery, it is important to use cord monitoring or wake-up test. Depends what is available to the surgeon. If you are using cord monitoring, it is essential to have a somatosensory and motor evoked potentials. I also use EMG to check peripheral nerves. In some cases, you might have excessive bleeding. Therefore, you should use cell saver. Reduction technique, accuracy of rod contouring is very important, and cantilever maneuver to reduce the deformity. What we are looking at this image, thoracic Scheuermann's kyphosis has got two components. One component is the thoracic kyphosis and lumbar hyperlordosis. In majority of cases, LIV either is L2 or L3. It means a part of these deformities in the lumbar region. You can't contour the rod completely towards the kyphosis, it will pull out. You contour it towards the thoracic kyphosis, and at the bottom part towards the lumbar lordosis that you can see here. When you have contoured the rod, of course, you fix it with proximal screws or hooks, whatever you have used on the top, and push the bottom part with 2 rod holders towards the distal screws that correct the deformity. As you can see in this case, thoracic kyphosis, the part is, and of course, this is a posterior vertical sacral line. So this is an example of posterior correction only, pontosteotomies and segmental screw fixation. What I want to show you here, the way I do pontosteotomies, we call it chevron osteotomy as well because it's a chevron shape. I remove the facet joints from here. This is inferior facet joint of this vertebra. You remove this one on either side, at 3 or 4 level you want. You remove interspinous, supraspinous ligaments. You do flavectomy here. And what is left here is the superior facet joint or level below, and you disconnect this one. And then you have done a proper chevron osteotomy or ponta osteotomies, as you can see here. This is an example of combined anterior-posterior correction. I used to do lots of anterior-posterior in the past because the segmental screw fixation wasn't very popular at that time. So I put the screws on the top and bottom and do the ponta osteotomies at the apex and correct the deformity. In majority of cases, in the beginning, I use moss cages at every level, and later I just use the rib graft. But nowadays, I do mainly posterior approach. What about posterior vertebral columbarization, PVCR? This is relatively very big operation for the curves more than 120 degrees. And those patients who are not a good candidate for anterior release, you have to do the whole thing from the back. It's a big operation. You expose the spine, expose the ribs, according to the size of the child, 2 or 3 level, remove 1 inch of the ribs on either side, remove the entire posterior elements here, as well as the vertebral body. As you can see, I usually put the screws on the top and the bottom. The level you want to do PVCR, you leave it without instrumentation, expose the ribs, excise the ribs, and then remove all the posterior elements, pedicles and lamina and vertebral body. Of course, you put this temporary rod there to prevent collapse when you are doing this job. When you have done one side, and put similar rod on the opposite side and repeat the same procedure from opposite side. What you end up is just a cord, spinal cord in the middle and nothing there. And then you close. I show you this is the same patient. This is a video clip. You can see, actually this is the spinal cord, and this is the rod there. And now you, I had to repeat this one twice to close this cap. You can see the rib is, the lung is inflecting. That's the example of this operation. It's the same patient, in fact, 120 degrees curve reduced to 50. Significant loss of sagittal balance by 10 centimeters. If you look at the pelvic incidence before and after surgery is the same. But if you look at the pelvic tilt, is much larger than this. So significant, you can see PI minus lumbar lordosis should be plus minus 9 degrees. Significant mismatch between pelvic incidence and lumbar lordosis before surgery. And this has shown plus this causing significant disability and reduces the quality of life in patients. When you're restoring by osteotomy, but performing surgery, and then all these elements, spinal pelvic parameters return to normal values. Now the difference between pelvic incidence 60 and lumbar lordosis is around plus minus 9 degrees. So returning to normal, and this SVA return to normal values. That's very important. The goals of surgery is alleviate pain, correct deformity within the normal range, taking into the account pelvic incidence. I will discuss this one later on. Restore global sagittal alignment, prevent curve progression, and correct end-vertebral selection to avoid PJK and DJK. Complications. Kyphosis greater than 100 degrees can affect pulmonary function. Surgical site infection and neurological complications are more common in Scheuermann's kyphosis than idiopathic scoliosis. Scheuermann's kyphosis has a higher risk of reoperation than adolescent idiopathic scoliosis. Instrumentation failure, hook or screw pull-out, is common after surgery in Scheuermann's kyphosis. Development of proximal junctional kyphosis or PJK after surgery occurs 1 out of 3 patients. So what is a proximal junctional kyphosis? Kyphotic angle between non-instrumented, this is a non-instrumented, and this is instrumented level. The angle more than 10 degrees is called PJK. Presence of PJK is often asymptomatic, but when severe, can be painful and unsightly. Most common cause of PJK is wrong selection of upper instrumented vertebra, inadequate contouring of the rods, soft tissue damage above upper instrumented vertebra, mismatching of kyphosis correction determined by pelvic incidence. I explained this one later on. If you look at these three images, cervical spine is more lordotic in type 1 compared with type 2, as well as the lumbar lordosis. Cervical lordosis decreased significantly following correction of thoracic kyphosis. This will reduce on type 2 will increase, and that will increase. So what do we want to understand of these changes? When just imagine this thoracic kyphosis is about 90 degrees. When you correct this one, definitely reduce cervical lordosis and lumbar lordosis. That now you have got a pelvic incidence almost 80 degrees. If we reduce lumbar lordosis from, for example, if it's 60, reduced to 20 degrees, still would be significant mismatch between pelvic incidence and lumbar lordosis. It's not 10 degrees anymore. And that happens in type 1, not in type 2. We found it actually in our number of cases that we have operated, 37 cases, the chance of developing PJK is much higher in type 1 than type 2, according to the size of pelvic incidence. So this paper we published in 2016. This study included 37 patients who underwent posterior correction for Scheuermann's kyphosis between January 2006 and December 2017. Those patients who developed PJK appeared to have a significant post-operative reduction of lumbar lordosis. Lumbar lordosis decreases after surgery following correction of thoracic kyphosis. Therefore, thoracic kyphosis correction should be planned according to preoperative PI values to avoid excessive reduction of lumbar lordosis in patients with a higher PI values. So in conclusion, a lower amount of thoracic kyphosis correction should be attempted in patients with a higher preoperative PI values in order to avoid post-operative mismatch between lumbar lordosis and pelvic incidence and consequently PJK occurrence. What about distal junctional kyphosis? Majority of these patients are overweight and obese. The common cause is wrong LIV selection and inadequate contouring of the rods towards the lumbar lordosis. Look at this case. This patient was instrumentation extended to L2, while if you draw this line, posterior vertical sacral line, L3 was LIV. So and the rod wasn't contoured properly. In this case, the rod was contoured and extended to L3 and solved the problem. So use of TP, how can prevent this one? Use of TP hooks proximally, preservation of the proximal ligaments. That's very important. On this slide, I can't see a part of my slide. Here on the top of the instrumentation, if you, I show it on this one because I can't see the other one. When the metal is here, if you damage the soft tissue above the metal, interspinous and supraspinous ligament, so the tension band in the back of the neck will go and neck will fall down and you develop PJK. But in this particular case, this is one of my cases, 6 months later, she came because PJK, because the rod wasn't contoured on the top properly. So avoid mismatch between PI and lumbar lordosis. I will tell you now. So here you are. This is the same patient. When I see this patient, I saw this patient, she was very, very upset and painful in this region. What was the option? What were the options for me? Either to remove these 3 screws, put the larger screws there. I wasn't very sure that can hold it. Whether extend it to the neck, but in a 15-year-old girl, you want to extend the instrumentation to the neck, that wasn't a good idea. So I came with this idea. Removing these 3 proximal screws and contour the rod laterally towards the ribs, and then put hooks on the T2, T3, T4 ribs with the interconnecting rods and plenty of bone graft. As you can see here, the problem was solved and the patient was so happy. This is another case where it's referred to me, another hospital. I did exactly the same on this case. You can see that problem didn't resolve. Over the years, I've used different techniques. This is another technique I used, passing a flat elastic band around the first rib, crossing and fix it down here. This is another technique. And this one I use in elderly patients for adult scoliosis of adult deformity. So T2, T3 are usually to vertebroplasty and put the screws there, but you need this additional fixation. This is a cervical rod and hook on T1, T2, 3 ribs, and this additional prevent PJK in elderly patients. This is an example of cases, my early cases, all of them had a Moss cage, as you can see here. There wasn't segmental fixation, instrumentation on the top and bottom, and punctal osteotomy in the middle, but a good result, as you can see here. But the issue was the incision from anterior surgery, as you can see here. Good correction achieved with combined procedure. Sometimes I use cages, sometimes a bone graft. But when I put this one to compare combined procedure with posterior procedure, similar cases, this patient had front and back, 95 degrees curve, and this one has 95. Post-surgery 40, and this is 42. This patient had front and back surgery. This patient had just posterior surgery with punctal osteotomies. But this is a segmental screw fixation with the punctal osteotomies at the apex. So I don't need to do front and back in adolescent anymore. I just do the whole procedure from the back. You can see a number of cases after that I've done. All of these cases had punctal osteotomies at the apex and segmental screw fixation with a good result. Here you are, these are all cases, 95 degrees to 40 degrees with a good correction, and they were very pleased. Again, all these cases you can see a good result have been achieved. This is a very interesting case. This patient, I think it was age 30 or 35, had an operation in Manchester by one of the surgeons there for Scheuermann's kyphosis. They put instrumentation here, and this was complicated by infection. So they tried to keep the instrumentation in place and treat this infection with a combined antibiotic therapy. He was in hospital for 4 months. They couldn't control the infection. He developed fistula in his back here. And finally, they decided to go and remove instrumentation, and he needed also they actually discovered the spine is solid in this position. Also, they needed a skin graft. When he was referred to me, he was completely loss of sagittal balance by 10, 15 centimeters, neck deformity, and quite disabled. I didn't want to do anything with the thoracic spine, with the past history of infection, solid bone, and the skin graft. The only area I had to operate was the lumbar region. So my first plan was not to correct the deformity, to have a good foundation. I did a 4-level anterior interbody fusion with cages. Second stage, I did L3 osteotomy. As you can see, SVA returned to normal, and neck position corrected spontaneously, and he was very pleased with this operation. So you can just correct the deformity in this region if you end up with this sorts of complications. This is another interesting case. A lady, age, I think was 38 or 40, attended my clinic with this global kyphotic deformity. The young age, she was diagnosed with the upper thoracic Scheuermann's kyphosis. As you can see here, I was using SurgiMap at that time to see how I can correct this deformity. SurgiMap showed me I can do 5-level punctal osteotomies at the thoracic region and subtaxial osteotomy at L3 region, and this is what has been done. Showed me this is what should do, and this is what I did. I did multiple thoracic osteotomies, punctal osteotomies here, and then lumbar osteotomy here. For global kyphotic deformity, you have to go to the pelvis. You can't stop L3, L4, L5. You have to go to pelvis. You need a 4-rod construct here, because when you do a lumbar osteotomy, you're disconnecting a spine from front and back. With significant stress in the rod, 80% of the rods will break up within 3 or 4 months after surgery. So you have to use 4-rod construct to enhance the fixation and put a plenty of bone graft here. You don't get this problem in the thoracic region because of the rib cages protecting you, but in the lumbar spine, you have nothing if you do osteotomy with lots of stress here. So a good correction was achieved. If we look at this one, I'll show you the images of X-rays and patients' photographs. Here you are, 90, approximately 100 degrees curve, reduced to 45. She didn't have any lumbar lordosis. Now here you are, that's been created. Of course, pelvic incidence doesn't change. Pelvic tilt, as you can see here, much larger after surgery, return to normal values. Now, if you look at the images, look at the neck position after operation. The thoracic spine is corrected. You see a spontaneous correction of the neck deformity. That's the thoracic spine reduced, lumbar spine created. This is, look at this lady's underpants here. This is a retroversion of the pelvic pelvis, which is actually a compensatory mechanism, as well as the knee flexion. This is compensatory mechanism to keep this lady straight. But after surgery, it's just returned to normal, and knee flexion deformity is spontaneously corrected. So by this operation, you can make a lot of changes in the neck, in the knee, and in the pelvis, and correct the deformity. And she was so pleased with the result of this operation. So we have published numerous papers about Scheuermann's kyphosis over the last 25 years. And this is my conclusion. Treatment of Scheuermann's kyphosis has evolved significantly over the last decades and is still controversial in many aspects. There is a limited role for brace nowadays. I don't use brace anymore. Posterior only correction methods are favored. Segmental pedicle screw fixation and punctal osteotomy, in my opinion, is the treatment of choice. Combined anterior posterior fusion may still be needed to correct more severe and rigid deformities in adults. PVCR is indicated in patients with severe deformities and pulmonary dysfunction. Now you can see here, this is the operation I did probably 6 or 7 years ago for European Spine Journal. I don't have a possession of this film. I got a small scattered sections of different parts of the operation, but whoever wants to see the whole operation, I think they charge 9-10 euros European Spine Journal to allow you to see the whole operation. But I'm sorry, I'm just going to the scattered sections of this. I'll show it to you here. These are the making holes in the pedicles. These are the guide pins. I don't use X-ray in my operation. It's all freehand. This is the position of the patient on the operating table. Montreal mattress, midline incision, exposure, subperiosteal dissection using diathermy. This is a screw placement freehand technique, and this is the area of the osteotomy. It's very scattered. I mean, I try to be with every section. There's the punctal osteotomy. You can see osteotomy, the facetectomy is performed, and osteotomy is performed. Interspinous, supraspinous ligaments removal, as well as the spinous processes. Here you are. These are the facet joints removed, and you, as I mentioned, you do inferior facet joint, the contouring of the rods. That's closure, but shows a little bit more of, this is my preoperative planning. I put the size of the screws I want to use and the area of osteotomy and the size of screws in the bottom. That will help my sculptness to put all these screws on the table. So this operation, if everything is available to me, probably takes 3 hours to do. So that actually speed up the operation. Again, that shows the exposure, removal of spinous processes. Sorry, it's scattered. It's not. It's also very convenient. I want to show you the. These are the guide pins. You should be very, very harmonious when you put them because it's a freehand technique. You look at them and put the screws all the way through, and that's the screw placement. I want to show you the osteotomy a little bit. Here you are. It's facet joint removed. This is the superior facet joint below, and you connect it here and there, and remove all these elements here, and you perform here. You're done, and you put the screws at last at the region of osteotomy. Don't put it in the beginning. You put the top and bottom, and this is the last part. You can put the screws at the osteotomy site. I think that is the end of this. I don't think there's anything more. And then, of course, now rod, you fix the proximal here on both rods to the right and left, and then push them down towards the head of the screws in the bottom part, and you finish the operation with the correction. Thank you very much for your attention.
Thank you, Professor, for a wonderful lecture, for sharing your insights and valuable experience. I'd like to, I don't see, I see only one question in the chat, but I want to ask Professor Hayati Aygun to ask the question himself, if it's possible.
Sure, yeah.
Yeah. Professor Hayati, would you like to ask a question to the presenter?
Do you hear me?
Yes, we do.
Yes.
First of all, I want to thanks for excellent presentation.
You're welcome.
It's a very
Pleasure.
nice presentation, really, and also the operation videos. I just wonder that, many of authorities hesitating to reach to D2 instead of D4. So what's your opinion? I think
Yeah.
you always reaching to the D2,
That's
right?
correct. That's a very, very good question. I think in my experience, you see, if you go to T4 or D4, you call it, it still is a part of the kyphosis in that area. When you go to T2, you're very close to the cervical, which is the lordosis. So it means that when you complete the thoracic region to go to T2, you get an excellent fixation. I've never had any problem, but if you put it on T4, there's a chance of PJK is very, very high in my experience. It will pull out because it's still in the part of the kyphosis. You have to complete, when you go to T2, you pass the kyphosis, you're just getting close to the cervical lordosis, and that prevents PJK. That's my personal experience with 37 cases.
Very nice. So even in type 2, you want to go to the D2, right?
Yes.
Okay, thank you. So second question, I have second question. Sometimes do you need to put the cages, corpectomy cages or others, when you do the
PVCR.
osteotomies?
Yeah, I mean, of course, with the subtraction osteotomy, no, I mean, I don't put anything there. But with the PVCR, some people use Moss gauges in front. And in my opinion, that might just prevent you to get a full correction. You can use a small cages there, but I think if you put plenty of bone graft there and close the gap completely, I think that would be sufficient. In those cases, I've done PVCR. I never use cages anteriorly, but some people do it. Of course, if you are doing this operation for the tumors, there's a different issue, or for fractures. But I think for Scheuermann's kyphosis, majority of cases are adolescent. They will fuse so quickly between 6 to 12 weeks after surgery.
Thank you. Thank you very much, sir.
You're welcome.
Thank you, Professor Hayat Aygun. For those in the audience who might not know, he is the chairman of the Turkish UB Society. And this year, in 2024 February, he is organizing International Spine and Endoscopy Congress in Bursa, Turkey, with its cadaver course. I encourage you to participate and to know more about the course. Thank you, Professor Hayati. Thank you, Professor Mehdian, for your response.
You're welcome.
And now I would like to give a word to
Mehdian, can you please stop your screen sharing so we can see each other bigger?
Right. Let me just stop sharing. Yeah. Okay.
Okay, perfect.
Thank you. And now I'd like to give a word to Professor Haluk Berg. He is a past head of the Eurospine.
He's a good friend of mine. He's a great man. I know him very well.
Oh.
Okay.
Wow. Good to see
Hi,
you.
Alec. How are you, my friend?
Hi.
Are you okay?
I enjoyed listening to your
You're welcome.
lecture. That, as usual, it was
You're welcome. Yeah.
fantastic. The long-lasting experience on Scheuermann's and then other aspects of the spine. Yes.
Welcome. Yeah.
And we had the chance to discuss these issues in the past. So I was just want to ask one little question. For the selection of the inferior level in the Scheuermann's kyphosis, you recently started to use the vertical line, sagittal vertical
Yes,
line
yes,
passing through the posterior end of the sacral plateau.
yeah.
I think this is a recent concept, but what were you doing in the 2000s and 2010s? I was using the Chopin's criteria of a hyperextension X-ray and
Yeah.
looking at the first lordotic level
Yeah.
where the disc starts to open. And I think these two levels coincide well if one makes a, I think, look back at the past cases. I really want to know your opinion. What were you using in the past, and what made you to change that level decision?
Yeah, I think my personal view is, I mean, before even introduction of these posterior, finding LIV through the posterior vertical line, my personal view was type 1, you should always go to L2, and type 3, because the lower thoracic, you go to L3, and sometimes L4. Depends actually where the apex of the deformity is. That was my personal view. I didn't use hyperextension. Of course, I use hyperextension X-ray to assess the rigidity of the thoracic curve, but not in the lumbar region. I think that SVA probably I used in the long time ago to see how I can actually is intersecting with the lumbar vertebra and choose that one. And of course, as you said, I mean, that might be that technique of Chopin also worked very well. But usually you're talking about between T2 and T4. That these three levels, which one to use depends the type of deformity, upper thoracic, mid thoracic, or frontal lumbar.
The upper level, I totally agree. Below T3, in our series of Scheuermann kyphosis, we went into trouble. When we were lowered down to T3, especially T4, we had a higher incidence of complications of pullouts, hooks, dislodgement, and everything. And T2 is safe. And thank you for stressing to preserve the ligamentous structure.
Absolutely.
At least 3-4 levels below the upper instrumented level. So meticulously preserve the posterior ligament. This is the theta that would help you to prevent more. I have no experience in the elastic bands. I have read and reviewed the manuscripts with that, but I don't have any experience with that. But it might work, as you have shown to us. And that is the important complication of the Scheuermann's disease also. Yes, thank you. And good to see you.
Lovely to see you. Let me just say something else. I mean, what I actually found there, I had one patient. She was very, very obese and overweight. She had a massive breast. I had actually sent this patient to plastic surgeon to reduce the size of the breast, because even you extend it to L3, the weight in front of the body pulls the whole instrumentation out. So my recommendation, if you have a majority of DJK cases, they are very, very obese. You have to consider this one. I think sometimes you may go a bit further down to prevent DJK. Lovely to see you, Haluk. I hope to see you in the next.
Yes, thank you. There are other questions waiting for you to answer.
Okay, no problem.
Thank you, Professor.
Thank you, Professor.
For the contribution.
You're welcome.
Thank you. I will now proceed in the chalk part. I see Dr. Ayaan Kanat is asking, what is the reason to remove spinous process during surgery? Is there any study which compares removing the process and without removing?
No, a spinous process is a part of the fusion process. I mean, if you don't remove it, you can't fuse the spine. You have to remove the interspinous, supraspinous ligaments and get access to do decortication of the laminae. I mean, this is a part of fusion process.
Thank you. And Baran Taskala is asking, thank you, sir. As far as I see, you perform LC-PSO. Do you think it's physiological to perform L3? Because mostly apex is L4 or L4-5. Second question for PJK, do you prefer proximal thoracic PSO? Thank you again for the excellent presentation.
Yeah, I mean, my favorite level for subtraction osteotomy is L3 because what I need enough fixation below my osteotomy. Some people consider L4, and what we have got L5 and pelvis. If you use L3, you have got L4, L5, and S1, and also pelvis. You have a very good fixation below. You don't get any problem with the instrumentation failure. And of course, it's surgeon's preference. Some people, I mean, the issue with L3 is below the conus as well. It's less risky. I'm not very keen to go higher up. And all cases I've done, numerous cases with the subtraction osteotomy. L3 is the best level I can choose for a subtraction osteotomy. What was the second question?
Second was about PJK. Do you prefer proximal thoracic PSO?
No, I mean, I'm not, I mean, as I said to you, I mean, with the point osteotomies, you can get a significant correction. There's no point to do that. Or you can go as many as you want point osteotomies, and then you don't need the subtraction osteotomy in that region.
Okay, I don't see any questions in the chat, so I will proceed from the audience. I see you have Sinan Erdogan. Do you want, Dr. Sinan, do you want to ask your question?
Okay, is Sinan with us still, or?
Oh. Okay, I will use this time to ask a question of my own. Professor, you are one of the pioneers of the spinal instrumentation. My question is, do you see the future of endoscopic approach in the correction of such severe deformities as the Schmorl?
To be honest with you, I'm probably old for doing these new minimally invasive procedures, but I'm sure there will be future. At the moment, they can't do the large and severe deformities endoscopically, but I'm sure in future they will succeed with the new techniques. But to be honest with you, I'm not very good in endoscopic procedures. I've done thoracoscopic surgery in the past, or even minimally invasive doing anterior interbody fusion. But I leave this sort of job to the young people because it's a long learning curve, and you have to start at a very young age and then continue with this. Yes, I'm sure there would be some.
And thank you for your honest response. Thank you very much. Professor Hassan, do you have any further questions?
I want to thank again to Professor Mehdian.
You're welcome.
For this excellent lecture, and probably some of my residents will want to go to England to see his operations if he accepts.
Okay, we will contact in due course.
And I want to repeat your announcement about this endoscopy congress. I will be the one of the speakers.
Excellent.
In this congress, and Professor Hayati Aygün, I want him to make an announcement for the congress, because I believe that it will be a good chance to learn some endoscopic aspect. Please, Professor Hayati Aygün, can you?
Yeah, thank you for valuable opportunity for announcement our meeting. We have a meeting in Bursa city in Turkey. It's maybe many of very famous and important speakers and lecturers will be together with us in Turkey. And you know, endoscopic surgery is very difficult for the surgeons, but is good for the patients. And to getting good result is very difficult because it's depend on many criteria, many other issues. So the learning of the endoscopy is needs to long time, and also it's very expensive. So it will be a good opportunity for especially in young surgeons. We will have a cadaveric course in Uludağ University Anatomy Laboratory, and then we will have a good meeting in Almira Hotel. So I want to invite you and all the other neurosurgeons and orthopedic spine surgeons. I think it will be a good chance for us. Thank you for your opportunity. Thank you very much.
Thank you, Professor.
My only good experience with the minimally invasive, which I was so pleased, as I said, I'm too old, but you're young guys, you're the future of the spinal surgery, you can do all these minimally invasive far better than me, was the technique I used. Actually, we published this technique, treating discitis and vertebral osteomyelitis through the minimally invasive procedure. And we created a good suction irrigation system with 2 portals, and then we treated a number of cases with the discitis without operating, or just opening the tummy and just go from front or from the back. So that was very, very good. This is my only experience with this minimally invasive.
Thank you. Yes.
Thank you very much.
Excellent. That was a great pleasure to work with you guys, and I hope in future we continue to work with each other.
Yes.
Thank you very much.
It was a great pleasure having you. I thank you sincerely, and I thank the audience for their contribution. Thank you.
Thanks a
Thank you
lot.
so much.
Okay,
See you
bye.
soon.